Good evening, friends. Let's start with this session. Going to talk about various question answer session posed by all of you one by one. And then I'll try to show you all the various abnormalities which I have in my armamentarium to clear your doubts. To begin with, I'll request Dr. Pasanjit. Are you there, Dr. Pasanjit? Are you able to hear me? Anybody, Dr. Amit?
Yes, sir. Dr. Prasenjit here. I can hear you.
Dr. Pasanjit, please tell me anything you want to ask for.
Sir, I'm just getting the book, sir. I had noted down some questions.
Yeah, please.
Right, sir. Sir, give me some time, sir. Let others ask their questions.
Okay, fine. I'll go to Dr. Rupali now. Rupali, you have some question?
Yeah, sir. Sir, actually, I'm Rupali, not Dr. Rupali.
That's fine. Does not make any difference as long as you are in this medical field.
Yeah, sir. Actually, I want to ask, what is levocardia, sir?
What's that?
Levocardia, sir. Means many times our cardiologists mention on the report levocardia also, sir. So situs solitus.
I showed you that phenomena. I'll just tell you like in simple format what is levocardia is. Just give me a second. Let me share a slide. This is what is, can you see the slide?
Yes, sir.
This is a subcostal window. This is anterior, this is posterior, this is left, this is right.
Yes, sir.
You can see my arrow also?
Yes, sir.
So this is left side, this is right side. When we open this subcostal window, the RV and RA, they are anterior to LV and LA,
Okay.
and right of the LV and LA. So this is right of LV and LA.
Okay, sir.
So this is left side, this is left side, this is right side. When this thing happens, this is known as levocardia.
Okay, okay, sir.
Otherwise, what is another is dextrocardia.
Yes, sir.
When this dextrocardia is, this heart is on this side, opposite side.
Means same RA on right side only and left.
Let me just try to rotate this slide so that dextrocardia would be, we have this left ventricle facing to right side.
Okay, okay. Means index marker is on same position that when we are taking the
marker would be same position at 3 o'clock, but the heart would be not on the left hand side. LV would be directed towards right hand side.
Okay, okay. And sir, situs inversus mein ulta.
Situs inversus is a form of dextrocardia where all organs are on opposite side.
Okay.
Dextrocardia means only the heart is on the left hand side, right hand side. In inversus, spleen is on other side, liver is on other side. They reverse completely.
Okay, okay.
So the technology is situs solitus with D loop. This is D loop. And this is known as levocardia.
Okay. Okay, sir. Thank you so much, sir.
Right. Okay, Prabhali. Dr. Amit Vikram. Dr. Amit Vikram, are you there? Dr. Sanika Kadam.
Yes, sir.
Sanika, go ahead.
So sir, good evening. I'm also a technician.
I know, Sanika. Look, it always look good to call you Sanika, Dr. Sanika and Dr. Rupali.
So I want to ask on the same question. Now you explain about the D loop. I want to know about the L loop.
You want to understand about L loop, right?
L loop.
Okay. Now, what exactly is, I can't show you like on a screen right now. How do I show this? Give me a second.
Okay.
In fact, my image is not visible, so I want to show you what exactly.
So this image is visible.
No, like something like I want
Another.
to-
Okay.
All right. This is what slide is.
Okay.
I was trying to show you my slide, basically myself as a slide. It says when normal embryogenesis happens,
Mhm.
the heart tube folds to the right, that's D loop, and pivots to occupy this position in the chest of left side. So the RV develops anterior into the left, right of the left ventricle. This is known as D loop. When this same thing, it rotates not to the right, it rotates to the left.
Okay.
And what exactly will happen in that particular scenario? If it rotates to the left and occupies the left side of a chest is, this LV and LV, they'll be anterior to RV and RV. Got my point?
Yes. Yes.
This is situs
Yeah.
solitus D loop with levocardia.
Yes.
So when D loop happens, RV, RA, they're anterior and to the right of LV and LA.
Okay.
If it rotates to left side, that is L loop, the LV and LA, they'll be anterior and right of the RV and RA.
Okay. Change.
The reverse happens.
Reverse.
Same things are present over there.
Okay.
If this image rotates to other side, this becomes dextrocardia,
Okay.
right?
Reversible. So that will be LV apex towards the right
Right side would be
side.
dextrocardia.
LV dextrocardia. So one more thing. In the ASD, I would like to see the unroofed coronary sinus ASD if you have any.
Good.
clip.
I'll just show you unroofed coronary sinus. Give me a second. I'll show you an unroofed coronary sinus. All right. This is a 35-year-old female. She had breathlessness for a long time. She had 4 echoes done before. They were non-conclusive. And again, we did an echo which was challenging for us. Now look at this echo. There's nothing specific in this. But look at this image over here. What do you see in this image? And in this image?
First image is parasternal long axis.
Correct.
There is a flow in from LA.
Some amount of mitral
No.
regurgitation is seen over here.
Yes.
Not more than
Yes.
that. Correct?
Yes. Yeah.
But this image is very specific. Look at this image.
Yes.
This is short axis view at LV. This is LV,
Yes.
this is RV.
Yes.
First of all, RV is bigger, LV is smaller.
Bigger. Yeah.
Right?
Looks like a
And
little bit
look at this
D-shaped.
D-shaped ventricle,
D-shaped.
but this D-shaped is only during diastole, not in systole.
Yes. Yes.
It means it's a volume overloaded condition.
Volume overload.
This is pulmonic flow, which is normal. And this is TR jet, which gives a velocity of almost 4.19, 3.11 meters per second and a gradient of 40 millimeters of mercury. Right. Now, see the next clips. This will be comfortable for you. Now look at this clip over here.
Dilatation of RARV.
RVRA, they are dilated. LVLA, they are smaller in size. So what exactly this answer would be? There's something which is related with this volume overloaded condition from where it is coming, but intra-atrial septum was intact. Now, what we did, gave a contrast to right arm first.
Okay.
So it's opacified, the right arm is normal. Then we gave a contrast to left arm. So whole of the left side heart was opacified, not the right side. And subsequently, right side the heart was also opacified. So contrast in left arm, contrast in right arm.
Right.
Normally what will happen, if there is a ASD, you'll give a contrast on right arm, it will spill over to left arm from a
Bubbles.
atrial septal defects.
Yeah.
So why this is happening? This answer would be given by this image. This is an image this is normally left internal jugular vein communicates with right internal jugular vein and drain into superior vena cava. When this thing happens with a persistent left-sided SVC, it gives way to right atrium. So persistent left-sided SVC is also always present. And this left-sided SVC is perforated over here.
Okay.
Before it drains to coronary sinus and right atrium, this is perforated over here. So what will happen? Once you give a contrast to left arm, this will come and opacify the left atrium, left ventricle first, and then right atrium and right ventricle later. And this is not there. This is obliterated completely. So this is known as unroofed coronary sinus.
Okay.
So if you are suspecting this kind of a picture where RV, RA, they are dilated and you don't have any answer with giving a contrast to right arm, you can't see any shunt across it, try to give a contrast on left arm also.
Yes.
But be very careful, because once you give a contrast to right arm, what will happen? The contrast which goes to left arm, this contrast will go to coronary circulation as well as to cerebral circulation. The patient could have fall of blood pressure and as well as a decrease in sensorium levels.
Okay.
So this is what exactly happened in our lab. When we gave a contrast to left arm, she became really drowsy and her respiration dipped. So what we did, we gave her mafantine, whatever we had to increase her blood pressure. This is like working in cath lab when we start to inject, when we accidentally used to inject air into the coronary circulation, we used to jack up the blood pressures. Right?
Okay, sir.
This is how we diagnose unroofed coronary sinus. And then we finally got a cardiac CT done. And that was a bilateral SVC, right SVC to RA, left-sided SVC large, coronary sinus with large ASD present, unroofed coronary sinus.
Okay. Simultaneously, the CT report also required.
Correct.
Okay.
Sir, is
so
the
one more-
LSVC always perforated
Pardon, is always perforated.
into real? Okay.
If it's not perforated, what will happen? It will come and drain into the coronary sinus.
Coronary sinus. It will be known.
So unroofed means the coronary sinus which is perforated and giving rise to contrast to left-hand side first.
Okay, okay, sir.
Otherwise, what will happen? This will be only persistent left-sided SVC,
Yes, sir. Only LSVC.
only LSCC.
Okay, sir. Thank you very much.
Okay.
Thank you, sir.
Dr. Prasenjit here. Can I ask the questions?
Yeah, go ahead, Prasenjit.
Sir, I just jotted down something when I was being taught about transposition of great arteries. Concordance versus discordance. I cannot make out. I have jotted out something and not able to understand. Can you just tell me something about it?
मंगला में थोड़ी देर में कॉल करूंगा, क्लास में होगी.
Hello?
Yeah, Prasenjit.
I noted something like concordance versus discordance, you had told something. I have noted down, but not able to recollect, sir.
Okay, I'll show you that concordance versus discordance. Can you see my slides?
Yes, sir.
Okay. So look at this slide, Prasanjit.
Sir.
Nitin. So if this is left side, this is right side, what exactly is happening? LA is communicating with LV through mitral valve, right?
Right, sir.
RA is communicating with RV through tricuspid valve. And how do we say this is tricuspid valve? Because this is apically placed.
Correct, sir.
Now look at this slide now over here. This is LA because we have a left-sided atrial appendage. This is right coronary vein, right pulmonic vein. He's a left pulmonic veins. But this is communicating from LA to RV. RV, this is trabeculated RV. And the tricuspid valve is apically placed on this side. So this is known as atrioventricular discordance.
Okay.
On the other hand, RA is communicating with LV through mitral valve because mitral valve is basically, this is a hinge point of tricuspid, this is a hinge point of mitral valve.
Okay, sir.
Correct. So the
Right, sir.
which is apically placed means towards apex. This is tricuspid, which is basally placed is mitral valve. So this is right atrium to left ventricle through mitral valve. This is atrioventricular discordance.
Correct. Correct, sir.
Clear?
Yes, sir. Yes.
Perfect.
Second, sir.
Go ahead.
About Epstein's malformation that was explained, sir. There was something like a attenuation of proximal part of RV. I had noted it down. I'm not able to recollect, sir. Mentally, I cannot get that picture.
Okay, give me a second. I'll come down to that Epstein malformation.
Because these cases we hardly see, sir. Only YouTube I saw one or two somewhere.
That's not an issue. Don't worry about it. I'll show you like what is. This is, you can see the slide? Not yet.
Not yet, sir.
Okay. Now you can see the slides.
Yes, sir.
So this is left atrium. This is left ventricle. This is right atrium. This is right ventricle. Correct?
Right, sir.
And if you happen to see very carefully, this is septal leaflet. This could be anterior or posterior leaflet. I cannot say 100% conclusively. I'll say this is posterior leaflet.
Sir.
So this septal leaflet is, if I've tried to stop it in between, is this septal leaflet is getting plastered to interventricular septum up to this point.
Yes, sir.
So this is left ventricle. This is all left ventricle. But this left ventricle has become smaller. RA has become bigger.
Correct, sir.
So this is known as atrialization of right ventricle. Right ventricle becomes more like an atria. Now see this very carefully. This is posterior leaflet. This is flail-like posterior leaflet, large leaflet. But this septal leaflet is all plastered to the interventricular septum, interventricular septum.
Right, sir.
So effective tricuspid valve is seen over here. If you happen to see a jet in this patient, the jet will come from this point. The jet would come from this point of a tricuspid valve. Now this is further zoomed up picture. This is all septal leaflet. It should be over here. But this septal leaflet is plastered and now it's attached to almost apex of RV.
So,
So this is a point from where the TR jet will start arising. And this is what inverted V, which we use often when we look at these kind of a thing. This is LA, this is LV, this is RA, this is RV. And this is known as atrialization of right ventricle. This all area is known as atrialization of right ventricle.
correct.
I hope I'm able to give you a correct answer. What's do you mean by Epstein anomaly? And
Sure.
now it is said that if you happen to see this Epstein anomaly, normal cases is what I said, apically placed tricuspid valve and basally placed mitral valve, right?
So,
So this mitral valve is inserted over here and the tricuspid valve is inserted over here. Insertion point remains the same. But
right,
here
sir.
the insertion point has gone to this point. If this distance is more than 7 millimeters per meter body surface area,
Okay.
then it's known as Epstein anomaly. The gap between hinge point of mitral and tricuspid valve more than 7, some people say 7, some people says 8 millimeter per meter body surface area, then it's known as Epstein anomaly.
So, right. And thank you, sir. Sir,
Okay.
one more thing.
Yeah.
One more thing. I just bought the book by Dr. Parasar and Dr. Amuthan sir on echo. It's a very difficult book. Actually, I was going to that chapter 34, that cyanotic congenital heart disease. They've classified so many things. So I don't think I need to require those, sir. As a physician, so I think I need.
No, you don't need to
ASD,
require all these things,
Right. So ASD, VSD, if I can make out tetralogy follow to some extent.
At
And,
your level, if you are able to differentiate atrial septal defect, ventricular septal defect, coarctation of aorta, then PDA,
so,
pathology of fellow, transposition of great vessels,
so,
that will be more than enough.
right. Thank you, sir.
Nitin, any questions further?
Yes, sir. I would like to know about that is the correction of the great arteries, sir. Partially corrected and also totally corrected
There's nothing
pulmonary
like
vascular.
partially corrected or nothing like totally. It is transmission of great vessel, which is corrected congenitally or
Yes, sir.
TGV. Right?
Yes, sir. Please, yes. I would like to know about that, sir.
Okay.
And how do they look on the echo, sir, when we do?
I'm going to show you only echo pictures. I'm not going to
Yes.
show you anything else more than that.
Yes, sir. Yes, sir. Yes, sir.
There's no fun talking of anything else apart from echo pictures.
Yes, sir. Understand.
Yes. All right. So what exactly does this mean by Nitin?
Sir,
Issue is, look at this picture again. This is right atrium, this is left atrium, this is left ventricle, this is right ventricle. Sorry,
no,
this
sir.
is left ventricle, this is
Yes,
right
sir.
ventricle.
RV, sir. Yes, sir.
So this is transposition of great vessels. Correct. Now, if this transposition of great vessels is present, now you go to the next. Now this is better seen over here without colors.
Yes, sir.
Now it's better seen over here without colors. Like this is mitral valve, which is basally placed, tricuspid valve, which is apically placed. This is
Yes, sir.
RV, this is LV.
LV. Yes, sir.
Now we go to this three-chamber view. This is three-dimensional picture. Same thing is seen in three-dimensional picture. This is mitral, this is tricuspid, this is RV, this is LV. This
Okay,
is all comes from that we have got transposition of, this is atrioventricular discordance, correct?
Correct, sir. Yes.
Now we go to short axis for the same patients. If we go to the short axis of the same patient, what exactly happened? What I said in the initial period is, if you happen to see two vessels lying
Next to
parallel
one
to each
another.
other.
Yes, sir. Yes, sir. I remember.
This is one vessel over here, this is second vessel over here.
Yes, sir.
They are lying parallel to each other. So this is what transposition of great vessels.
Okay, sir.
So this vessel is not bifurcating, this vessel is bifurcating.
Yes, sir.
So what is this? This is known as congenitally corrected transposition of great vessels. Why is that? Because the vessel which appears to be reverse, now this one vessel is arising from morphological right ventricle, which is
Sir, how-
LV,
Yes, sir.
and it's bifurcating.
Yes,
On
sir.
the other hand, the other vessel is arising from left ventricle, which is morphologically right, and it's not bifurcating.
Correct. Aorta, sir. Yes.
Aorta. Not this is aorta, this is pulmonic artery, and this is pulmonic artery, this is aorta. So these two vessels, they are parallel to each other, giving rise to transposition of great vessels. But on other side, they have the same thing like atrioventricular discordance. So what exactly does it mean by? Left atrium is connected to right ventricle, and right ventricle is giving rise to aorta.
Okay, sir. Yes. Yes.
On the other hand, RA is connected to left ventricle, and left ventricle is given rise to pulmonic artery.
Yes, sir.
So this is known as congenitally corrected transposition of great vessels. Dr. Niharika, please silent your mic. Dr. Niharika.
Sir, it means that it is actually twice corrected
There
itself.
are two abnormalities in the same patients.
Yes, sir.
And if you happen to see only this, it means that we are dealing with transposition of great vessels.
Sir, in this picture, sir, can we if we see a patient, sir, how to say that which is aorta? Because aorta, I said, which was actually in the 3D, it was at the bottom, but you told it is pulmonary artery in the 3D, sir.
Any of these two vessels will be bifurcating. Let me just play this clip.
Can you show the bifurcation, sir?
Let me try. In this picture, yeah, it should be. Wait a minute. So this is one vessel which is bifurcating,
Yes, sir.
one
Yes,
over
sir.
here, this second
Yes,
over
sir.
here. So
Yes,
this is
sir.
pulmonic artery, the other
Correct.
vessel is aorta. This is aorta.
So what is below is aorta, sir, then?
Below is aorta, top is pulmonic artery.
So, sir, in the short axis, can we make out more about RVOT and aorta coming out of it?
Yes, certainly, we can do that.
Sir, could you show such a picture?
Okay, just give me a second.
Because that I think will be more useful than.
Yeah, it is, no doubt about it. All right, I've got it one. Give me a second. Okay, can you see my slides now?
Yes, sir, we can.
Okay. So now you identify this is subcostal window. This is so-called LA. This is LV. Here is RV on top. And this is most probably, I cannot say anything right now. Let me just look at this picture. This is known as absence of
IIS, intrathecal
intrathecal
septum.
septum defect. This is known as septum primum defect, basically.
Yes,
You
sir.
can see some part of the remnant of intrathecal septum over here.
Septum. Yes, sir.
Correct.
True. Yes, sir. Understood.
Now you see something like VSD out here. Something like VSD.
Yes, sir.
So this is common utilization of both atrias. There's common chambers.
Yes, sir.
Now you see carefully, this so-called right ventricular is giving rise to two vessels at the same time. One vessel is going over here
Ah, yes, sir. That looks like LVOT, sir.
and other vessel is, now you see this double, one vessel is going over here, second vessel is going over here.
Yes, sir. Yes, sir.
Two vessels which are arising simultaneously.
Sir, the one actually below looks like LVOT with aorta.
No, this is aorta, which is up here. This is pulmonic artery, which is bifurcating.
Oh, yes, sir. Yes, sir.
This is aorta, which is not bifurcating.
Correct.
And
I
both
understand,
of these
sir.
arteries will have a separate color
Exit.
flows pattern now. Look at this.
Exits. Yes.
This is aorta, which is not bifurcating.
Yes, sir. True.
And this is bifurcating. Correct?
True, sir.
And it shows turbulence. I'll come back to it. It shows turbulence. Now this is PDA.
Oh, yes, sir.
So that's how we look at these vessels when we talk of transposition of great vessels. Both the vessel will start arising apparently from a same vessel area, and one will bifurcate, the other will not bifurcate.
Sir, is it like something like a single ventricle? Something like
It could be sometime a single ventricle, this thing,
Triology.
DORV,
Yes.
double outlet right ventricle, or tetralogy of Fallus.
Yes, sir. Understand, sir. Thank you, sir.
Right. Dr. Raj Borkar. Pankaj.
Yes, sir.
Yes, sir. Yes, sir.
Raj
Dr. Pankaj,
Borkar,
sir.
go ahead. Raj Borkar.
Okay.
Yes, sir. So I wanted to know if there is any anatomical marker for left and right ventricle. Let's see if we by chance miss assessing the valve levels, are there any markers to identify left and right ventricle?
Yes, they are.
So can you please show?
I'm going to show that. You give me a second. Can you see my slide, Raj?
Yes, sir.
So what is the anatomical markers for right and left ventricle, right?
Yes, sir.
First of all, left ventricle is clean shaven. It's a triangular kind of ellipsoid or bullet shaped structure. Then it does not have any accessory bundle or muscular band. Then always this left ventricle has got two papillary muscles, lateral and inferior, correct? Right ventricle is
Yes, sir.
always tuberculated, heavy tuberculated in apex. It is triangular in shape, does not have any papillary muscles. That's how we differentiate these two ventricles. It's written over here, right ventricle tuberculated, chordae inserted into ventricular septum. There is accessory or motator band in apex, is triangular in shape. This is ASD, that's what it looks to be bigger. Then
Yes, sir.
tricuspid valve is apically placed. We are not considered what tricuspid valve because tricuspid valve can go to mitral along with LV or RV also. But majority of time at your level is tricuspid valve always goes with RV.
Yes, sir.
Is that clear,
Sir,
Raj?
yes, sir. So I had one more question.
Go ahead.
So what is the role of suprasternal wave in coarctation of aorta?
Suprasternal view in coarctation of aorta. So I'll
Yes,
go to suprasternal view in coarctation of aorta. So give me a time. Let me just go to coarct. So this is suprasternal view in coarctation of aorta. So this is ascending aorta, this is arch of aorta, this is descending aorta, right?
Yes, sir.
The quart could be preductal or postductal. At your level, you have to forget about this. Coarctation is when it's present in the descending thoracic aorta. Correct? So
Yes, sir.
when you see a suprasternal window, you'll be able to see the quart as seen over here by presence of a turbulence distal to left subclavian artery. Here is the left subclavian artery. So distal to left subclavian artery, there is a turbulence which is present, and this is known as coarctation.
Yes, sir. Sir, the role of gradient measurement across all three parts of aorta?
So gradient measurement across all three parts of aorta is not there. If it's at the level of aortic valve, that is aortic valve. At coarctation of aorta is over here. So what you do is you put a sample volume just before the quart. So I did a sample volume just before the quart. So it gives me a velocity of 1 meter per second with a gradient of 4 millimeters of mercury. Then I moved my cursor into the quart and aliasing started happening. So I had to switch over to continuous wave Doppler. Now you see this Doppler spectrum pattern, you are able to see one over here and the second faint Doppler spectrum pattern over here, correct?
Yes, sir.
This is continuous wave Doppler across this quad and the gradient is almost 3 meters per second. So the
Yes.
effective gradient across quark is 36 minus 4. That is gradient before the quark, which is 32 millimeters of mercury. Anything more than 20 is considered as abnormal.
Thank you, sir.
Clear?
Yes, sir. Thank you, sir.
Okay, right. Dr. Pankaj,
Yes, sir. Sir, my question: how to detect the LSVC?
how to differentiate LSVC? Okay.
Detect, right, sir.
All right, let's go to LSVC now. Can you see my slides now,
Yes, sir.
Pankaj?
Yes, sir.
You look at this slide again and again.
Right.
So I'll freeze it for you.
Sir.
So this is left atrium, this is left ventricle,
Right, sir.
and look at this structure over here. Behind LA. Now when this slide moves, just look at this structure over here. Behind LA, which you will not see normally. There's two structures behind LA, not one, there are two of them are there. So this is one descending aorta, this is another descending aorta. If you happen to see this structure, this is dilated coronary sinus.
Right, sir.
And when you happen to see this coronary sinus, then you always suspect persistent left-sided SVC. How will you suspect SVC? Here's a diagram for the same thing. No, I'll not like to confuse you with that diagram. I showed you that diagram earlier also, and I'll bring that diagram back to you. Just give me a second.
Right.
Okay. You can see this diagram.
Yes, sir.
So the same thing which I showed earlier, this is persistent left-sided SVC, it drains through right ventricle through coronary sinus.
Coronary sinus, right?
So this coronary sinus, if it's dilated, then
Yes.
we'll be able to see this as left-sided persistent SVC. Now the question comes, how do we diagnose this persistent left-sided? When we see that kind of a structure out there, which I
Yes.
showed you a couple of minutes back. So what do? We give a contrast to patient's left arm.
Right, sir.
So this part is blocked or this is obliterated. So whole of the contrast will come and opacify
The right
first
atrium.
the dilated structure and then the right atrium.
Right, sir.
What does it mean by? It means by, if I go to my previous selection of slides, so when we'll give contrast to left arm, it's going to opacify the structure and followed by right atrium.
Sure.
That's how we diagnose it.
Okay, sir. Normally, if you infuse any contrast in the left arm, it will directly come to the SVC, then comes to RA. In this case,
Even
it
if
will
you
come
give a
to
contrast to left arm, it will only opacify the
right atrium. Initially.
right atrium only.
Right, sir. From
Whether
the,
you
through
give
the
to right or
SVC.
left, it does not make any difference.
Right, sir. Sir, another question. How to detect subaortic VST and perimembranous VST?
Okay. First of all, let me remind you that we still follows 1980 Soto's classification,
Yes.
SCTO Soto's classification. This is a diagram from 1980 Soto's classification. Even after 42 years. Why? Because we classify only VSD as inlet, outlet, paramembranous, and subpulmonic.
Right.
Correct.
Right.
So inlet is when we see, no, we do not see any aortic valve. Is only 4-chamber view. We happen to see inlet, like mitral and tricuspid valves are seen. There is no aorta, which is known as inlet. If you happen to see a VSD, this is not an inlet VSD.
Right.
If you happen to see a VSD when aorta is open, that is known as outlet VSD. So it means by this VSD is a septum. This VSD is an anterior septum.
Right.
Correct?
Right.
So this is known as outlet VSD. Then comes paramembranous, which is seen in Plaque's window. This is paramembranous.
Right.
Now, next question comes, what's a diagram which I have made by myself? So this is paramembranous. We go to short axis view at aorta.
Okay.
This is 1/3 is paramembranous. Then last 1/3 is doubly committed VSD or subpulmonic VSD.
Right, sir.
And this is known as outlet muscular VSD.
Right, sir.
So this is how we classify them. And this paramembranous VSD would be seen in plaques window again.
Yes, sir.
Outlet muscular VSD would be seen in during 5-chamber view.
Okay, sir.
And this doubly committed VSD is always associated with aortic valve regurgitation and prolapse. Right?
Right, sir. you,
Nathan, you want to ask something?
Thank you, sir.
Yes, sir. But sir, you are talking about 4-chamber view and yes, and actually VSD being seen, and again opening up the aorta and VSD being seen, sir. But we can make 4-chamber into 5-chamber also, and actually 5-chamber into 4-chamber. Then how to make out, sir?
This septum is a dicey structure which has got an anterior septum like over here and a septum. So when we talk of inlet VSD, this is inlet is means septum per se. And when we talk of the anterior septum, this is an outlet VSD.
Sir, aorta has to be present to make it outlet, sir.
Outlet VSD.
Aorta has to be seen, sir.
Aorta has to be seen. Outlet means when the outlet is seen, that is outlet VSD.
So any interventricular septum seen with aortic view, okay, then it becomes outlet VSD.
Outlet VSD, and that outlet VSD could be majority of time this is muscular or paramembranous. This part is paramembranous. If you rotate this image, this
Yes,
becomes plaques window.
Correct, sir. Yes, sir. True.
So if it's seen over here, this is muscular, this is paramembranous. And this is all muscular. Lower muscular, mid muscular, upper muscular.
Okay, sir. There are so many names actually, sir.
That's
two
what
or
I'm
three
saying.
names for each.
I'm just trying to not to confuse you. I'm
Yes,
trying
sir.
to make it very simple. We call them as 4 type of VSD.
Yes, sir.
Inlet VSD, outlet VSD,
VSD,
paramembranous
member-
VSD, and subpulmonic VSD.
Yes, sir.
I was just discussing today with one of the pediatric cardiologists. He says, sir, even today in 2023, we are still following 43 years old classification because it tells to an interventionalist what exactly is going to do with their managements.
And sir, there are so many oblique names that are written in the books. Sir, can we just omit those and
Forget
remember?
about them. Forget about them.
Yes, sir. I understood, sir. Thank you, sir.
Any questions? Anybody from this? 2 people raise their hands.
Good evening, sir.
Amit, go ahead.
Sir, no, I want my question was about on the sir, types of VSD in the pastoral short axis view, sir. So, do you
Right.
have any echo image of this, sir?
Echo image of this
Same diagram, sir. Do you have?
same diagram, echo image. Yes, I should be able to show you one image. Give me a second.
And sir, if you can, you please show all the 4, sir, VSDs in one after the other. That would be really helpful.
Now, what is this kind of a VSD is?
Muscular, sir, as you explained.
What muscular?
Mid-muscular.
Outlet
Mid-muscular.
muscular.
Outlet mid-muscular.
Yes, sir. Sir, why is it outlet, sir?
Aorta is seen?
Oh,
Yes.
very simple, sir, actually. Yes, yes.
This one?
Aorta not
Alright.
seen, sir. So aorta is not seen. It is actually mid-muscular again.
Inlet.
Inlet, sir.
Inlet mid-muscular VSD.
Yes, sir.
This is muscular mid-muscular VSD.
Short axis, sir, that is.
That is
And
short axis.
It is at, say, sir, 12 o'clock position. So
that is not 12 o'clock position. That is short axis looking at the interventricular septum alone. Don't commit with that image of aorta.
yes, sir. So this is what we call this, sir. The one
Muscular
right.
VSD.
Yes, sir. With the aorta, it is at around, say, sir, can we call it as 12 o'clock or not, sir?
We cannot say this is inlet or outlet. We can say muscular VSD. To commit as inlet or outlet, we have to go to 5 chamber or 4 chamber.
Yes, sir. Understand.
What is this VSD?
It is membranous, sir.
Paramembranous VSD. Which
Paramembranous
is
VSD.
just before the aortic valve.
Aorta, sir. Yes, sir.
And now, what kind of a VSD this is?
That is also just below the aorta, sir.
Yeah, this is bidirectional. Look, there's a flow of color on both the sides. Red as well as blue.
Yes.
Bidirectional flow is present. And
So
what do you mean by
happens in Eisenmenger, sir?
bidirectional?
So what happens in Eisenmenger, sir?
So bidirectional means LV and RV pressure, they have almost equalized.
Equal.
Something like Eisenmenger, sir?
Maybe an Eisenmenger, I cannot say Eisenmenger, but my quest of showing bidirectional flow means LV and RV pressure, they are almost equalized. Eisenmenger would be exclusively when the pressures are RV is more than LV. Here, still flow is seen from LV to RV. Right?
Yes, sir. Sir, something there is called as supracrystal and all that.
Forget about, that's what I'm saying. Please forget about that.
Yes, thank you, sir. I will. That's
So
a great.
the representation of this paramembranous VSD in short axis view is, now look, this is a hole over here in first third of
Aorta, sir.
aorta. If it's over here, it's muscular. And if it's over here is subpulmonic.
Doubly committed or
doubly committed. Doubly committed means committed to RVOT as well as to
LVOT, sir.
LVOT. Oh, sorry, pulmonic artery. And this will be always associated with aortic regurg. And when we happen to see this kind of a doubly committed VSD, it always needs surgical closure. Whether this paramembranous, whether this doubly committed, they always need closure by surgical means.
The subaortic and subpulmonic in
You can, some people just give me a second because Anchal, you asked me some different question. I would rather commit it as doubly committed VSD rather than subaortic or subpulmonic.
okay.
Because now with this imaging, you know wherever is the VSD is, or just remember 4 type of VSDs, nothing more than that.
Sir, are the paramembranous and the perimembranous same, sir?
Periparamembranous is same.
Okay, okay.
Is that fine?
Yes,
sir. Definitely, sir. Yes.
Okay. Just give me now 5 minutes break. I'll pick up a cup of tea or a water, and then I'll come back again. There's a call coming up from Bangalore again and again. Dr. Satish Govind is trying to call me up. Give me 2 minutes, 5 minutes break. I'll come back immediately. Right?
Okay.
So I think we are done with this. Let's move on to Dr. Shedab Raja. Shedab, you have to ask anything?
Sir, this can you show, sir, this overriding of aorta, sir?
Overriding of aorta. Okay.
Yes, sir.
So that's known as tetralogy of Pellow. One of the feature of TOF, basically.
Yes, sir.
So this is one picture of overriding of aorta, Dr. Shedam.
Yes, sir.
This is aortic valve. This is always aorta. This is right cornicus. This is non-cornicus. This is interventricular
Yes, sir.
septum, and this is the VSD, right?
Okay. Yes.
But
We
this
are very close. Yes, sir.
this interventricular septum, instead of being attached over here, this is projecting in between this aorta,
Okay, sir.
and that's why it's known as overriding of aorta.
Okay, sir.
Let's look at the next picture very carefully. So now you see that aorta is somewhere in between of the interventricular septum. So you can
Yes, sir.
say in
Yes.
one go,
Yes,
this
sir.
is a type of VSD, but there is along
Yes,
with
sir.
override of aorta.
Yes, sir. Yes.
And if you happen to look at
Thank you,
colors,
sir.
colors would be like both the flow would be going in one direction at one go.
Yes, sir.
Like during systole, LV would be pushing blood to aorta and RV would be pushing the blood to the aorta.
Yes, sir.
Correct? So
Yes,
this
sir.
is known as overriding of aorta, and this is associated with VSD.
Yes. Thank you,
Okay.
sir.
All right. Aarti Jadhav. Aarti, are you there? Dr. Sanjeev Mathur. Swapnil.
Yes, sir. You just
Sanjeev,
told
go
about
ahead.
the overriding of.
Yeah, I
Can you
explained
hear me, sir?
overriding of aorta already, Sanjeev.
Yes, sir. But the overriding of aorta is also present in a tetralogy of LSR.
Yeah, it is part of a tetralogy of fellow associated with DSD, pulmonic stenosis, RV hypertrophy.
It's the same one which is associated with TOF.
Correct.
Okay, sir. Thank you. That's it for me for now.
Sure. Swapnil.
No, sir. No question.
Rota Singh Kalsi.
Yes, good evening, sir.
Good evening.
Sir, can you please show us some slides like in suppose we have interatrial septal defects, like those patients with left to right shunt and those who are having like Eisenmenger's or right to left shunt, sir.
Okay. So best part to show this slide would be show by a contrast echo. I'll show you two cases, one of ASD, second is PDA.
Good morning, friends. I'm Dr. Rakesh Gupta, who's going to pick up all these cases of interesting challenge.
Can you see the slides now, Dr. Ratas?
Yes, sir.
Okay. So this is when we gave a contrast to this patient. Look at this negative contrast over here. There's this filling defect which is present with this contrast. Now ASD is present, but there's no shunt reversal. This is known as negative contrast. You can see it very carefully over here also. Right? Now this is zoomed up picture for the same thing. Now this is a flow which is from left to right. If this flow reverses or there's no flow across it, then we call this Eisenmenger syndrome as far as ASD is concerned. I'm not able to locate one film showing reversal of flow. For the timing, if I'll get across somewhere, I'll get back to you. Now it's there already. Now you see this, it's already there. Now I was trying to locate this picture. With systolic reversal, there is a flow which is going from right atrium to left atrium, which is blue in color. Now see this slide carefully. I'm going back to this slide. Every systolic contraction, there is a reversal flow from right atrium to left atrium. You hardly see any flow from left atrium to right atrium. Can you see this?
Yes, sir.
Let me make it more comfortable for you. Now see it carefully now. You see some amount of flow which is seen going from left to right. And with every systolic beat, there's a reversal of flow is present. Now I'll try to stop and move it gradually now. Every second with systolic, there's a reversal of flow in descending aorta, this left atrium, yellow, blue in color. That's what is a reversal of flow in atrial septal defect. Now, let me show you a slide where complete Eisenmenger has happened already. So this is classical PDA, short axis view at aorta, and this is descending aorta and left pulmonic artery into descent. And there is a reversal from patent ductus arteriosus through ductus arteriosus from aorta to pulmonic artery. Clear? This is also the same ductus. Now in this patient, look, RV is bigger than LV. With every systolic contraction, interventricular septum is bulging towards LV. When we did a short axis view, RV and LV with systolic contraction, interventricular septum is bulging towards LV. It means RV pressure is more than LV pressures during systole. So when we go and see a short axis view, now there is a descending patent PDA is present, but you cannot see any reversal of flow with every systolic contraction of LV in this particular view. Why? Because RV pressure are more than LV pressure. So what does it does? It drives blood from this RV to descending aorta rather than reversal of flow which is present. And this is proved by giving a contrast. We give a contrast to right arm, and this contrast has opacified the descending aorta. So this is what is PDA with reversal of flow, which is Eisenmenger syndrome. If you happen to same thing in PDA or VSD or in atrial septal defect, that's what is Eisenmenger syndromes are.
Okay, sir.
right?
Right, sir.
Okay, let's move to Dr. Rahul Kumar.
D loop, L loop, you have already explained, and about transposition of great arteries. You have already explained.
Anything else, Rahul?
No, sir. Sir, only top, you have almost shown the overriding part.
Overriding and
Yes,
VSD. Along with
yes,
the pulmonic stenosis
Pulmonary
and
stenosis and RVH.
RV hypertrophy, which you measure in subcostal window.
Yes, sir.
More than 5 millimeters. All right, Rashri Karat. Are you there, Rashri?
Yes, sir.
Okay, please ask me anything you want to ask.
Yes, sir. I just want to know about situs solitus inversus on 2D as well as the right aortic arch, sir.
Oh, I'll try to find out right aortic arch. First, situs solitus and situs inversus, first of all, right? When you put your transducer into subcostal window, which is vertical, what you get, this is spine, this is descending aorta, and here is IVC. Correct?
Yes, sir.
You can't see IVC right over here, but this is IVC, which is seen over here is these structures. So in situs inversus, what will happen? This will go to right hand side and IVC will come to left hand side. And that's why once you open this aorta, open up this image, the LV will transform to right hand side. Correct? Is that clear?
Yes, sir. But do you have any images of inverses, sir?
Situs inversus.
Yes, sir.
Remember, when I'm showing you an image of live demonstration next week, I'll show you situs inversus. Ask me this question.
Okay, sir. Okay, sir.
Right. This is one part you asked me, and let me see right-sided aortic arch. There is, I think I've got one of them for right-sided aortic arch. Give me a second. There's one patient of a right-sided aortic arch we did record, and I've got it in my computer. Unfortunately, I do not have any right-sided aortic arch, Rashri. I'll show you, send you on a WhatsApp, right-sided aortic arch.
Yes, sir. Thank you, sir. Thank you.
Thank you.
And to all, sir, if possible.
No, I'll send to the group, basically.
Yes, sir. Yes. And sir, an echo picture of TAPVC and PAPVC, sir, finally, please.
Wait a minute, I'll show you TAPVC right now.
Yes, sir.
Just give me a TAPVC. Just give me, I was seeing total anomalous pulmonary venous stage. Yes. All right. Give me a second. I'll just settle them down. All right. I made a quick fresh presentation because can you see my slides now?
Yes, sir.
Now look at this very interesting picture. What is this picture is? This is RV, this is RA, this is LA, and the LV, and here is a small chinky LV, LA. Can you see this small chinky LV over here?
Yes, sir. Yes, sir.
All the pulmonic veins, instead of draining to LA, they are draining into this common conduit over here. Look at this left over here, right over here. Can you see this right pulmonic vein and the left pulmonic vein over here? They are
Sir, are they
draining into
enlarged?
this. Pardon?
Are they enlarged, sir? Pulmonic veins?
This is left. Look at my arrow over here. This is left pulmonic upper. This is upper. This is lower. This is right pulmonic vein, upper and lower.
Okay, sir. Okay.
All these pulmonic veins, they are draining into a common chamber, which is draining into RA. Now look at the colors. You'll be able to see much better. Here is the MR jet. Don't confuse with MR jet. This is pulmonic venous drainage is happening into these all four veins are draining into this common chamber, which is draining into RA. Now look at carefully, very carefully. And there is an atrial septal defect out here. Not atrial septal defect. This conduit is draining into RA.
And sir, what is that interatrium septum like half, sir? That is
right?
Yes, sir. Yes, sir. Hanging. Yeah.
Yeah, this is not hanging basically. This conduit, which is draining all this structure, these veins, is draining into RA, and this is conduit basically.
Is that a membrane, sir?
This is a structure. Here is LA. Here is RA. In between, there is a structure which is a conduit.
Okay, sir.
Let me go back to this first picture. Look at this. This is a conduit. This is one pulmonic vein left. This is right pulmonic vein. And there is mitral valve. This is small LA, which does not have any drainage of pulmonic veins. Normally, this pulmonic vein will drain into RA, LA.
Yes, sir.
So this structure, this will be seen over here like this, normal circumstances.
Yes, sir.
Second picture is very categorical. You look, left pulmonic and right pulmonic vein are draining into this conduit, which is draining into right atrium.
Yes, sir. Yes, sir.
So this is total anomalous pulmonic venous drainage. So if you happen to look dilated RVRA, the commonest cause of dilated RVRA is, first of all, is always ASD. Second is, if you can't find any reason, then start looking for individual pulmonic veins, whether this total or partial total anomalous pulmonic venous drainage. Right?
Yes, sir. Understand. Sir, when we mean a total anomalous pulmonary drainage, so it applies to pulmonary arteries only. Sorry,
Pulmonic
pulmonary
veins, not arteries, pulmonic,
yes,
all four pulmonic veins. Partial means 2 will drain, 2 will not drain.
And sir, where will they drain, sir? Into LA?
Normally, pulmonic vein drains into LA.
But in case of PAPVC?
PAPVC, they'll drain into this common structure, then drain into RA.
Okay, sir. But
if it's
not
partial,
into LA, sir.
Partial means right pulmonic vein will drain into conduit and then into RA, and left pulmonic vein will drain into the left atrium.
Okay, sir. Meaning there is a partial drainage into LA as well then?
Yes, that's why we call them as partial.
PAPVC, yes, sir.
PAPVC. Partial anomalous pulmonic
vasculature. Yes, sir. Thank you, sir. Thank you.
Dr. Veerva Jha? Jha, are you there? Pratibha Madan Dhingra.
Yes, sir. Good evening, sir.
Good evening, Pratibha. Question?
Sir, I just want to see that isomerized PDA which you showed. Now that I could not get properly.
Okay, you want to see it again, right?
Yes, sir.
Give me a second. Okay, this is what you see are ductus arteriosus, which is patent during neonatal, infantile, or adult period, right? So this is short axis view at aorta. Here is aortic valve, LA, RA, tricuspid valve, RV, RVOT, proximal RVOT, distal RVOT, then pulmonic valve, which bifurcates pulmonic artery to right and left. And this is descending aorta. When you happen to see this flow from descending aorta to pulmonic artery, it means the pulmonic artery pressures are lower than systemic pressures, right? Is that clear, Pratibha?
Yes, sir.
Now, what exactly happens is, now if RV pressures becomes more than LV pressure, which is amply said by this slide, with every systolic contraction, this interventricular septum is bulging towards systole, towards LV. Now see carefully. With every systolic contraction, this septum is bulging towards systole, means RV pressure is more than LV pressures. Is that right? If
yes,
RV pressures are more than LV pressure, the flow which was happening from descending aorta to pulmonic artery during systole, because LV pressure or more than RV pressure, will disappear. Now the flow is happening from RV to descending aorta because RV pressure is more than LV pressure during systole.
Okay.
So how do we prove that? The first step gave us an answer. Okay, look, RV pressure is more than LV pressure. And then we did a contrast study in this patient. We gave agitated contrast saline. It did not show any reversal. But these bubbles from pulmonic artery, they went to descending aorta. And we were able to pick up in descending aorta by putting a probe into abdominal aorta.
Okay.
And when we saw these bubbles in the abdominal aorta, we were sure that this we are dealing with Eisenmenger in PD.
Okay, sir. Okay. Now I got it.
You got it? You must
Yes,
be wondering how these bubbles you said in descending aorta as reversal of flow.
Yeah.
So reversal of flow is coming from here, the pulmonic flow, which will go to right pulmonic artery and left pulmonic artery because of the patent ductus arteriosus is reversal. Now the contrast is going to descending aorta for pulmonic artery.
Okay, because of the reversal.
Reversal.
Yeah.
And we were able to see these bubbles into descending aorta. Abdominal aorta, descending abdominal aorta.
Okay, so there is reversal of flow.
This is known as Eisenmenger for PDA.
Okay. Okay. Thank you, sir.
Clear? All right, good. Sangeeta Chaudhary?
Yes, sir.
Go ahead, Sangeeta.
Sir, actually, yes, sir. I had 2 to 3 questions, sir. So,
Go ahead.
first of all, when you were teaching about the visceral situs, you told about subxiphoid and subcostal window. So, sir, are they different? You were saying like in subcostal we stay parallel and in subxiphoid we stay perpendicular.
No, subxiphoid, subcostal means same. Only
Okay,
fact what I was trying to say is, we put at a probe not parallel to the heart, but perpendicular to the heart.
Sir, can you just demonstrate how we do it?
Demonstration. Oh, that's not possible right now. Just
Okay.
make it remember when I'm showing you live demonstration next week.
Okay, sir.
What do you mean by perpendicular? What do you mean by parallel? Correct?
Yes, sir. Yes, sir.
Any next question?
Yes, sir. Sir, in transposition of great arteries, we were talking about when we go to short axis view, we'll see 2 parallel vessels.
Correct.
And the one which is bifurcating, that is pulmonary artery. So how from that view, how we modify to see the bifurcation?
Okay. Look, this is subcostal window in plaques, plaques window is short parasol short axis view at aorta, right?
Yes, sir. Yes, sir.
Now, if you happen to look at this point, when you angulate, their footprint looks towards right shoulder, these vessels will start opening up completely.
Okay, sir. Okay.
Like we are almost perpendicular in third intercostal space for making parasol short axis view at aorta. When our footprint will start looking towards right shoulder, these vessels they'll start opening up automatically. So this will bifurcate and this will not bifurcate, as I showed you previously in one of the slides.
Okay, sir. Okay. Thank you, sir. The last one.
Remember all these questions next Friday when I'm doing a live demonstration.
Okay, sir. Okay. So can I ask one more?
Go ahead.
Okay. Sir, in VSD, in parasternal long axis, when we see the color flow, be it perimembranous or muscular, when we see the color flow, how do you know that from which ventricle the flow is? Because like we are not parallel to the flow. So the color, how do we decide? I mean, in parallel, we will say like if it is blue, then it is going away from the transducer.
Now look at this VSD.
Yes, sir.
Tell me how the blood flow is going on.
It's a bit vascular, sir.
No. The flow is from left ventricle or right ventricle?
Left to right. Left to right.
And second thing is, Sangeeta, what you can do in these subset of patient is, you angulate your probe in such a fashion that you bring this LV slightly towards right hand side.
Okay, sir.
Like we always do that. Like if you come down to fifth, this is fifth intercostal space. You go to fourth intercostal space. So what will happen? This RVRA will become bigger in size and LV will tilt towards little on the lower side. So this shunt
Yes,
will
sir.
start seeing in a better way.
Okay, sir.
Second important thing in
From
ESD
this
is
flow,
whenever the hole is small, you'll have a turbulent flow. When
Yes,
the
sir.
hole is large or the pressure has equalized, the flow becomes non-turbulent. Look at this flow,
Okay, sir.
non-turbulent.
Yes, sir.
Just a minute. Now look, there's hardly any turbulence in this flow over here. Hole
Yes,
is
sir.
large and there is almost equalization of pressure.
Yes, sir.
sir, does this flow help us to tell it is membranous or muscular?
This flow only tells you about, the color flow tells you about VSD. Then direction of flow. But muscular or paramembranous is showed by the locations.
Okay,
So
sir.
from this window, can we say the direction of flow? I mean, how do we say the direction of flow?
Okay, now let me just hold on this picture for you.
Yes, sir.
This is at one time the blood is flowing from left ventricle to right ventricle because red in color towards the transducer.
Okay,
Is that
sir.
clear?
Yes.
Now let's move further. Let me just hold on that picture in blue color now. Yeah.
Yes, sir. It's coming. Yes. It's
Now
blue.
it's showing from right ventricle to left ventricle. That's
Left
a bidirectional flow.
Okay, sir.
It means, what does it means by? It means the pressure are almost equivalent to each other.
Yes,
Now
sir.
you can ask me one more question. Why, when the pressure are equalizing, why you are showing a red color and blue color together? Anybody can give this answer to me?
Mm.
Scratch your mind.
Sir, can you repeat the question, please?
When I say, Nitin, pressure has become almost equalized, then I say bidirectional flow is present. Correct?
Correct, sir.
So if the pressure, RV pressure is more than LV, then we'll have a reversal of flow from RV to LV. If there's a no reversal of flow, LV to RV. But
Yes, sir.
we are seeing both bidirectional flow. Why we are seeing bidirectional flow? When the pressure has become equalized.
Sir, it is because
due to respiratory variation.
Pardon?
This
is
due to contraction, sir.
What's, I'm sorry, say one by one. Dr. Subhash Chandra, say one. Dr. Subhash, you want to say something? Raise your hand.
So,
Achal.
so both the ventricle will get polarized at different times, slightly different. So one contraction, then the other. So because of that, there is initial flow from
The contraction time is variable.
variable.
Correct. One more thing, which is very important.
Sir,
Somebody
is
tells
it because of
respiratory variations.
Respiratory.
Sir, has it got nothing to do with the probe, sir?
No, nothing to do with the probe.
Direction of the flow of the blood.
It will remain the same. Once we
Is blue,
inspire,
towards is red.
once we inspire, what happened to RV pressure?
RV pressure should increase, sir.
LV pressure should decrease.
Decrease, yes, sir.
So respiratory variation will give us to these kind of things.
Is it not the flow that the probe picks, sir? Because one is away from the probe, one is towards the
No,
probe.
no. This slide is constant, man. Look at this slide. The timing of contraction of ILV and RV, and second, the respiratory variations will give us all this bidirectional flow when the pressure chambers have equalized. Good attempt.
Sir,
Anything? Yeah.
Dr. Prasenjit here, sir. Sir,
Prasenjit,
when you
go
put
ahead.
it, when you put a device, sir, for that ASD or VSD closer, how does it look? Just out of curiosity, sir. In echo.
First of all, take my words, majority of VSD are closed surgically, except for muscular VSD. Like this kind of a VSD can be tried for a closer device.
Sir.
I'm showing you the VSD.
Sir.
This can be attempted for muscular closer.
Sir.
Otherwise, doubly committed VSD, paramembranous VSD, they are all closed by surgical closures. I'll show you a slide. First of all, let me just, if you have touched that topic, management.
The cardiologist keep writing, sir, device in situ. How does it look actually?
In VSD, I'll show you ASD device. I don't have a VSD
Yes.
device.
Yes, sir. Right.
Look, this is a slide from one of the literature which I've picked up. Method of choice, device closer. Correct?
Sir.
Indication, mid-muscular VSD, anterior muscular VSD, postoperative residual VSD. Class 2B indications, not 2A.
Yes, sir.
Perimembranous VSD with at least 4 millimeter of distance from aortic valve. Where some people agree, some people do not agree. It means like majority of people, they do not agree.
Sir.
Contraindication, VSD with irreversible pulmonary vascular disease, pre-existence LBB, any AR, associated lesion requiring surgery, inlet or subpulmonic VSDs.
Sir.
Correct? Now,
Yes.
Method of choice for close of surgery. All VSD needs a closure of surgery by surgical methods. Except the one I showed you, the mid-muscular VSD possibly.
Sir.
Clear?
Yes, sir.
Now, let's see the device closure picture in ASD. This is a picture of device closure. Can you see this projecting device kind of a structure in interatrial septal defect?
Yes, sir.
Somebody has implanted a large oversized device in atrial septum.
Okay.
This is not always the same thing which it looks like. This is a small device which is hover around over here itself.
Sir.
And in ASD, the majority of ASD are closed by, because 80% of ASDs are mid-muscular ASDs. Sorry, secondum ASDs.
Secondum ASDs.
So today we are looking at their rims by 3-dimensional echo, transesophageal, and we close the majority of these secondum ASDs by device closure. So this is less than 4 millimeters is PFO, 4 to 8 is ASD, which needs observation, and more than 8 is always require closure. And this closure is by device closure. Like this is what another study of Jack 1993. So they need closure by
device.
If it's a primary VSD, primum VSD or SVC or IVC type of VSD, they need a surgical closure.
So in echo, sir, can you make out that surgery has been done? Is there any
normally there's a patch which is seen in this echoes. Hyperechoic patch would be seen over here.
Right.
And sometimes it's very difficult. Only like history will tell you that this patient has got a previous ASD closure by surgery.
Right. Thank you, sir.
Okay, right.
So what will be the implications of oversized device if they put in ASD? Like you showed that it was an oversized device placed.
The only implication is like they start projecting towards mitral valve. That's all. It's not causing any trouble over here, but it looks like it's projecting into the mitral valve, Sunita.
Okay, sir. I thought whether it will impede the flow or has any
No.
reasons for regurgitation or anything.
Look, it's absolutely separate kind of a structure which is overriding. Look, it's taking over this place, mitral valve. Nothing is happened, nothing over there. Otherwise, I can show you one more where this is absolutely right in the secondum part of ASD. Okay.
Okay, sir.
Dr. Ashok Yadav. Yadav, are you there?
Yes, sir.
Question?
No question, sir.
Ankit Seni. Achal. Shivaji Male. Everybody's tired, it looks like. Dr. Bhima Rai. Any question, Dr. Bhima Rai? Khushpreet Singh. Go ahead, Dr. Khushpreet. Any questions you want to ask? Archana Sinalkar. Archana, any questions?
No, sir. Do.
Then Prashant Pandey. Dr. Subhash Chandra.
Yes, sir.
Any questions, sir?
Sir, I've got the answer most of the questions in this deliberation, which is quite cumbersome for me. I'll try to read it, but it is not in the book. The book provided by you didn't give any congenital heart disease. And I was thinking to read, because today it was Sunday, I was not very busy, but I couldn't find it in any book.
Yeah,
so,
we are coming with the congenital heart disease training program next 3 weeks down the line. And I'm possibly trying to hold a video recording for all that.
That's right. Okay, sir. Thank you.
That'll be detailed and there'll be something new which will add to our training programs.
Thank you.
And sir, if you can also supply a DVD or a pen drive, we would like to buy it from you, sir.
Nitin, you don't have to buy, money is not the requirement. What
No, sir,
I'll
because
do, I'll record everything and
yes,
load on a website.
Sir. Okay.
It can be viewed by anybody.
Okay, sir. Okay.
I can tell you, sir, I've gone through MD, I've gone through membership, UK, everywhere. They just ask ESD, VSD, coordination, PD, and fellows. 5 things. That's all over the country. This is the first time I'm knowing about all these complicated things.
No, it's not complicated, Dr. Subhash. Like when we start doing pediatric echo, we can encounter any one of these are.
But it's very complicated
Yeah, it is complicated. No doubt. It needs patience and time,
Yes.
Once we have a pediatric child, it takes about 1 hour.
Yeah, that's possible. I have worked as a physician, either in India or in UK, never like a pediatrician.
Yeah, it's okay, fine. But at your level, if you diagnose ASD, VSD, PDA, coarctation of aorta, and then you say something which is not understandable and patient is cyanotic, I think that's more than enough.
Yeah, that's right. Okay, sir.
At least you can refer to that patient to a pediatric person for evaluation, or a good echocardiologist who does an echo evaluation of child, basically.
I think nowadays pediatric echocardiologists are available.
Yeah, they are available. All right.
Okay,
Dr.
sir.
Subhash Chandra is over. Now, Dr. Subhash Chandra from Punjab.
No questions.
No question, Dr. Subhash?
Thank you.
Dr.
No
Rajesh
questions.
Gudade.
Thank you.
Yes, sir. Can you tell about, sir, ASD versus PFO and a type of ASD?
All right. Why not? I'll show you everything about ASD.
Yes, sir. Sure, sir.
Yes, sir. I also wanted to know.
Sure. Let's go back to first ASD. Look, this is what a classification of ASD we are following in 2023. Primum ASD, secundum ASD, sinus venosus, which is ASD, SVC and IVC, then unroofed coronary sinus. If the ASD is closer to atrioventricular valves, this is known as primum. If it's present in the fossa ovalis region, this is known as secundum. And if it's present at the superior surface where IVC and SVCs are present, which is known as sinus venosus VSD. And majority of this type of VSD is not seen in transthoracic echo. Only we see indirect finding of dilated RVRA. Got it?
Yes, sir. Yeah.
So this is first ASD is when we see ASD in the secundum part, which is known as secundum ASD. So flow is there from left to right. Now, this is also seen in subcostal window in the secundum position. This is LV, this is RV, this is RA, this is LA, and this is secundum ASD. Next ASD is primum. This is another part of secundum ASD with the reversal of flow, which I showed you. This is a primum kind of ASD, which is the common AV canal defect. Look, there's no substance of ASD seen over here. If you happen to see us ASD over here, which is seen in the primum region, majority of time it present like common AV canal defect, which is like primum ASD, mitral and tricuspid valve, they become simply one. And this ASD these need surgical repair. All right.
Sir, why LA is dilated here?
The LA is not dilated. If you look carefully, LA is not dilated. LA is a single structure. This is one leaflet. This is common AV canal defect.
Okay, sir.
In primum ASD would be present in this part of ASD, will be very small. This tricuspid and mitral valve could be separate, but this is where the mitral and common, when this interatrial septal defect is present in this part of AV canal, so majority of time this becomes a single common AV canal defect, and this membrane dividing two structures, right and left atrium, completely disappears.
Okay, sir. Okay.
Right.
Yeah, got it.
Then comes sinus venosus type of ASD. The sinus venosus, this unroof I've already told you.
Yeah.
Then comes sinus venosus type of ASD, what we decide by looking at transesophageal echo. In transesophageal echo, this is known as 110-degree bicaval view. Bicaval means SVC and IVC view. This is SVC, this is IVC. If we happen to find a hole at this point, this is known as IVC type of defect. If we find a hole on the other side, which we call them as SVC type of ASD. This is an SVC type of ASD. This is bicaval view. Here is superior vena cava. This is LA, this is RA. If there's a hole which is present over here, we call them as SVC type of ASD. So this is how we look at this bicaval or transesophageal 110-degree view.
Yes, sir.
So in total, secundum, primum, Sinus venosus consisting of SVC and IVC and unroofed coronary sinus.
Yes, yeah. Okay, thank you,
In
sir.
all ASDs, only thing what will be common would be there will be dilated RVRA chambers.
Yeah.
Venkatesh Gowda. Are you there, Venkatesh? Dr. Niharika? Dr. Sunita Kaul?
So could you explain the PFO again with this so that
PFO.
we
Okay,
know that
let me just go to PFO. I'm sorry. PFO is a very small, tiny ASD. Now understand the pathophysiology of what is PFO. During normal embryogenesis, what happens? This is RA, this is LA, and majority of blood is coming from IVC, coming to RA and going to LA. So this is known as limbus. This limbus is open all the times. Correct? As the child is born, the LA pressure becomes more than RA pressure because the patient starts breathing. A lot of pulmonic venous flow starts happening. This limbus comes and attaches to the intraatrial septum. If there's a potential gap between this limbus and the intraatrial septum, and there's a flow of the flow of blood from RA to LA, sorry, LA to RA, then we call them as patent foramen ovale, which is seen over here. Now look at this without flow and look at this blood which is flowing from LA to RA. Can you see this blood coming from LA to RA?
LA to RA. Yes, sir. Yes, sir.
Blue color blood.
Yes, sir.
This is known as PFO. But at your level, how will you diagnose this PFO? That is the most important thing. Now let me show you a case of PFO. Give me a second. I'll just dig out a case for PFO. All right, slide 116. Now, this is what I was trying to show you. This is a patient whom we expected intraatrial septal aneurysm with dilated RV, RA. Now look at this is intraatrial septal aneurysm which is present. And there's a hole in, this is SVC, this is IVC, and there's a hole over here, which is known as IVC type of ASD.
Okay, sir.
Now you can see a flow of color from LA to RA. Can you see this color? Red
Yes.
color.
Yes, sir. Yes, sir.
Now, this is PFO. We injected a contrast saline into the RA, and you can see a bubbles crossing over from RA to LA with Valsalva. Can you see this color bubbles? Are they visible?
Sir, could you use the marker? I mean pointer once again. I can make out, but I'm not sure whether it's the same place.
Can you
what
see
I
these
am.
bubbles now?
Yes, sir. Yes, sir. They're crossing to this side from right to left. Yes, sir. Yes, sir.
This is what PFO is.
Is
And
it that we need to do T for PFO always to confirm it, or this?
we can do by contrast by transthoracic also.
Okay. Sir.
And in transesophageal, what we do today is we look at an atrial pouch. Let me show in 3D echo. We have an atrial pouch. This is what I was trying to tell you. This is limbus. This is RA. This is LA. So blood flows from LA to RA. When the intraatrial pressure builds up, this comes and attaches to the intraatrial septum, and which is seen like this over here. And this is, in fact, is seen like left atrial septal pouch, like this when we look at this intraatrial septum.
Okay, sir.
So at your level, just give a contrast. That'll give you a fairly good answer.
Okay. So could you also show coarctation of aorta, sir, please? Sorry.
Coarctation of aorta?
Yes, sir.
Okay, give me a second. All right. Sorry, give me a second more. Now this is arch of aorta. Can you see this ascending aorta, arch and descending aorta?
Yes, sir.
In this descending aorta, you see a lot of turbulence seen over here, and that is what coarctation of aorta. And don't do this is artifact, mirror image formation of descending aorta. So this is classical descending of aorta. And I showed this descending of aorta in my presentation also. Let me just go back to that presentation. One 169. Now you can see my slides. This is same picture from a coarctation of aorta. And how do we look at it? We just a pulse wave sample volume prior to quark, we keep it. We keep it over here. So that will give us a pre-quark pressure gradient, which is almost 4 millimeters of mercury. Then we move our cursor into the quark as we do in aortic valve. And look, aliasing happens. Then we have to switch to a continuous wave Doppler. And we see two sample volumes. Now one is pre-quark and second is through the quark. And this is almost 3 meters per second. The gradients are 36. And the effective gradient is 36 minus 4, that is 32 millimeters of mercury.
Okay.
So always look at a descending aorta, because that is where you'll find a lot of answer for your coarctation of aorta. I'll show you one more. That is possibly, let's interrupted aortic arch. If I'm able to show you that case. Instead of a quark is there, no doubt is there, but the aortic arch got interrupted there itself. So it's not only the quark only. The distal flow is not there at all.
Sir, is there any classification like mild, moderate, severe quotation of aorta based on the peak gradient?
No, no. Somebody asked me
sir.
this question in the morning also.
Okay, sir.
Look, if there's a quart, we have to operate that.
Okay,
if there's
sir.
a PDA, we have to operate a PDA. And the quart is one condition which we like to operate as fast as possible. Like newborn is a very simple surgery. Open from the behind and do a quart repair. So I'll show you this another one where this interrupted aortic arch is present. Very interesting kind of a thing which happens is a lot of collection which is there. I'm not saying like this collection is there for a day or so. It's there for long years. All right, now you can see my slides automatically. I'll straightway go to interrupted aortic arch. Now this is descending aorta. It may look a little difficult to understand. This is ascending arch and a descending aorta. And now look, there's no flow distal to this descending aorta. Let me just zoom up this picture for you. There's no flow distal to descending aorta. And the patient has just presented with this kind of a feature. Look, proximally I kept a cursor, distally there is no flow out there. And what we need, this patient has to be operated if we have to save this patient. There is no way out. All the flow which is getting through are ductus in this patient. Right? I think I'm able to answer you, Dr.
Yes, sir.
Sunita.
Thank you, sir. Thank you, sir. Thank you so much.
Dr. Iqbal Mohammed Mahmood.
Yes, sir. Present,
Go ahead.
sir. Sir, can you show me the rim of SBC and IBC rim? How we can assess transthoracic?
Transthoracic, I'll try. Because we do not do a transthoracic evaluation. We always like to do a transesophageal. But I'll try to make, because I have collected a few pictures for that. Let me do that if I can show you that transthoracic trans. How many rims do you want to see, first of all?
Sir, at least subaortic.
Correct. RV free wall, SVC and IVC, 4.
Yes, sir.
This is what we are going to do in February. And
Sir, I am trying to attend this, but I have some visa issue. That's why I'm waiting.
You are in India or outside India right now?
Sir, my visa expired within 2 days, so I applied. Not yet it is approved. So I'm not sure what to do.
You are in India right now or you're back to Bangladesh?
I were in Bangladesh and I came yesterday, and my visa will expire within 2 to 3 days. And I went to this FFR office. So they're not still extended. So maybe within 1 week, they will reply me. That's why I have not registered yet, but I'm planning for this, sir. I will.
Okay. Look, this is a 3D description of ASD rims picture. One is aortic, second is SVC, third is RV free, RA free wall, and third is
That is not
IVC.
visible. That is not visible.
It's not visible. I'm sorry. Now visible?
Yes, sir. Now visible, sir.
Okay. This is a 3D picture of aortic rim on this side, SVC rim on this side, IVC rim on this side, and this is RA free wall. Correct?
Yes, sir.
Now look at an SVC and IVC rim in transesophageal echo. So this is an IVC rim. Look, this IVC rim is deficient over here.
Yes, sir.
Correct?
Yes, sir.
And similarly, we look at an SVC rim by over here.
Yes, sir.
So bicable view, this is not like, this is, I'm sorry, this is, I said the wrong thing. My concept is that we do not repair SVC or IVC type of ASDs. Let's suppose fossa vallis defect is there or secundum defect is there. This would be the SVC rim. Correct?
Yes,
and
sir.
this would be the IVC rim. Because here the rims would be there and the defect would be over here. Are you able to understand me?
Yes, sir. I understand, sir.
So this is bicable view will give you this SVC rim over as IVC rim over here, SVC rim over here. So two rims will be able to see this particular window. Then we go to personal short we go to aortic view in transesophageal, where aorta is in the center. We look at the subaortic rim and RA free wall. That's separate topic altogether. And if you want to see this in transthoracic echo, just give me a second how I can explain you. Yeah, this is two views which we try to utilize in transthoracic echo is. One is atrioventricular and atrial views. This is AV, RV, LV, mitral and tricuspid valve. This is RA, this is LA. So this is one atrioseptal defect is present. And when we go to personal short axis view at aorta, we see this is subaortic rim over here. This is RA free wall rim and is the subaortic rim. But this is more classically seen in transesophageal echo rather than in transthoracic echo as on today.
So, sir, is it possible to assess SBC and IVC rim by transthoracic?
Unlikely.
Okay.
Some people, they try to do it, but it's difficult scenario.
Sir, another thing is when you push this contrast, how much you push just for
adult we use 10 ml, in pediatric 5, neonates 2. Give me a second. I think I had that presentation of looking at the rims by transesophageal echo. Because this is one of the most useful thing of a transesophageal echo is for ASD closure for long time, not for one day. I did present this topic once in Bangladesh Echo also, BD Echo also.
Yes, sir.
I'm sorry, can't. I'm sorry, I don't have that pictures right now, but it was there somewhere, but I can't dig it out. Okay. Anything else, Mahmood?
No, sir. Thank you, sir.
Dr. Bhagat Vibhusha?
Hello.
Yeah, Dr.
Sir.
Vibhusha.
Good evening, sir.
Good
Hello.
evening. Go ahead,
Yes,
Vibhusha.
sir. So for now, like whatever doubts I had, they're cleared. But so I'll read more in class.
Right.
Hello.
Any other question, Vibhusha?
No, sir. So I'll read more in the last next time.
Okay, right. Thank you. Dr. Prakhar Gupta?
Thank you, sir.
Prakhar? Dr. Prashant?
Yes, sir, Doctor. Yes, sir, Dr. Prakhar Gupta.
Okay, Prakhar, any questions, Prakhar?
No, sir, not really.
Dr. Prashant? Ankit Seni? Done. Mahesh Patsalge?
Yes, sir, I'm here. Only one question, sir. If I am doing echo for adult person, so what are the signs when I should think about congenital heart disease, like RARV dilatation or something like that? Hello?
I'll tell you with my experience.
Sir,
Whenever
that
you
is
see
experience.
large flow in pulmonic veins, when you happen to see large pulmonic venous flow, start thinking of some shunt.
Okay.
Normally, pulmonic venous flow velocity is only 30 to 40 centimeters per second. So go to fourth chamber view, look at the pulmonic venous flow. If you happen to see large flow is coming from pulmonic veins, then you start hunting for any shunts.
Okay.
Right?
And second question, sir. If see, like I have two things. Like once I had given one patient ASD small, and second time I missed. So and that patient was not having so much RARV dilatation also, and the defect was also very small, 3 to 4 millimeter. So is there any trick actually? So we cannot miss that ASD, because ASD is very common lesion in adult echos actually.
Yeah, the trick is like small ASD will not have any chamber dilatation. That's the problem with small ASDs. So if you go to subcostal window, if you counterclockwise rotate, you will get IVC opened up. Correct?
Okay, yes, sir.
If you, instead of counterclockwise, rotate clockwise in those subset of population and put a color. In clockwise rotation, RV and LV will disappear. Only you will be able to say intraventricular septum only.
Okay.
And put the colors out there.
Okay, sir.
That's one. Second thing is look at the flow velocity across pulmonic and tricuspid valve If the flow velocity across pulmonic and tricuspid valve is increased, then your ear should start ringing. Why my pulmonic and tricuspid flow velocity is increasing?
Okay. So that one patient, first when I diagnosed that time, because of small TRZ only I handled, and that time I got. But second time that TRZ was not there, RARV was not dilated, and then I just give a normal report. So that was a misconception.
So if it's the same patient you have missed in second time,
Yeah.
that could be normal also.
Okay, that could be normal also.
Because
Okay,
that small ASD would have closed by the time.
Acha. Okay.
Because I showed you that slide, anything less than 4 millimeters does not need any closure, means this closes spontaneously. Is only the limbus which has to, as the LA pressure will rise, the VSD will stop, ASD will start showing anything.
Okay, sir.
4 to 8 millimeters, you have to watch. More than 8 millimeters, they always need a closure.
So color flow mapping is very important actually in subcortical view. That
And
is only
color
the
flow
exam I
mapping
get.
is like flow velocity across ASD would be only 1 meter per second. 4 millimeters is a normal gradient. RA pressure is 10. Sorry, LA pressure is 10. RA pressure is 5. So only the difference of 5 millimeters of mercury is present between LA and RA.
Okay.
Sir, regarding sun fraction, can we measure the sun fraction, something like that out here, sir?
Say that, Birata?
Sun fraction, something pulmonary and systemic flow, something, there is one fraction I come across, sir. Sun fraction, it is called, sir.
No, this is known as QPQS ratio.
Yes, sir. QPQS ratio. So is it in the echo machine available, sir?
It is available in the echo machine. What is QPQS ratio? QPQS ratio is amount of stroke volume at pulmonic valve versus amount of stroke volume at aortic valve.
Okay, sir.
We have already seen the amount of stroke volume at aortic valve. How do we see aortic valve stroke volume?
Sir, we have to give a pulmonary.
We go to LVOT, take its diameter, get an area pi r square, multiply by LVOT VTI.
VTI, sir.
Correct. That will be the stroke volume at aortic valve or systemic stroke volume. You go to RVOT, look at the pulmonic artery diameter, RVOT diameter, get an area by pi r square, then took an RVOT VTI, that will give you pulmonic artery stroke volume.
Yes, sir.
So that is QP is pulmonic, QS is systemic, that is aortic.
Yes, sir.
As the volume of blood flow increases from pulmonic because of a shunt, this ratio will, normally this is 1:1 ratio. This ratio will increase from 1 to 1.5 and 2:1. If the stroke volume at aortic valve is 70 ml, the stroke volume at pulmonic valve would be 140 ml. That will be 2:1 ratio.
Yes, sir.
Correct?
Yes, sir. Thank you, sir.
Okay, right. Dr. Vivek Dwivedi?
Yes, sir. Yes, sir. No doubt, sir.
Dr. Shashank Tose? Dr. Prakash? Saurabh? Dr. Sangeeta Chaudhary? It's done already. Okay.
Present, sir.
Yeah, done. I've marked already.
Thank you,
Dr.
sir.
Bhardwaj? Avinash Solanki?
Yes, sir. Present.
Dr. Pranjal Jagtap? Pranjal, are you there? Okay. Anybody else in their attendance? Let me just know the names one by one.
Yes, sir.
UK Oja?
Yes, sir. How to administer the agitated saline as a contrast?
Agitated saline contrast is we use 10 ml of syringes, lockable syringes. And these 10 ml lockable syringes will add 1 ml, like 10 ml of what do you say? normal saline in one syringe, half ml of air in other syringe, by three-way cannula will mix with each other.
Okay, sir. Okay, sir.
And then we inject. That bubbles will get mixed to saline.
Okay, sir. Okay, thank you. Thank you.
Right. Anybody else? Any questions? Somebody?
Yes, sir. Myself.
Dr. Sheetal, tell me.
Yes, sir. How do we identify the anatomical right atrium and the left atrium?
Anatomical right atrium would have IVC drainage, or anatomical left atrium will have pulmonic venous drainage, and anatomical left atrium will have left atrial appendage.
Okay, sir.
IVC will always drain into right atrium. It has not drained into left atrium till date.
Okay, sir. So by using the subcostal view, we will
Subcostal
identify
view,
the
we look at an IVC, and from IVC, wherever the IVC open, that is morphological right atrium. The other atrium is morphological left atrium.
Okay.
Okay,
And you have to
sir.
identify left atrium by looking at the pulmonic veins. But pulmonic vein could be dicey, as I showed you, total anomalous pulmonic venous drainage. But left atrial appendage will always be there.
And the best view for left atrial appendage would be?
Parasternal short axis view at aorta or apical four-chamber view, angulation. Ask this question when I'm showing you live demonstration.
Okay, sir.
Okay, sir. One more, sir. My question is related to this question only. Sir, I have come across right atrial isomerism and left atrial isomerism. So, is it same with situs solitus or situs inversus, something like this, sir?
Left and right isomerism means when left atrium is connected to right ventricle and the valves do not change from each other.
Okay, sir.
Got my point? What I showed you were atrioventricular discordance. Atrioventricular discordance means LA is connected to RV through tricuspid valve.
Yes, sir.
But isomerism in left or right-sided isomerism is these valves do not change. Left atrium will go to right ventricle with mitral valve.
Okay, sir. Sir, could you show me in the next class, sir? Next.
Isomerism, sure.
Yes, sir. Okay, sir. Thank you, sir.
Sir, good evening, sir. Can I ask one?
Harsh, what's your full name?
Sir, Harshvardhan.
Dr. Harshvardhan, go ahead.
Sir, I want to just see the slide of tricuspid atresia, sir. RV hypoplasia.
RV hypoplasia. Okay, give me a second.
Yes.
All right, give me 1 second time because let me just organize these slides for you. All right, we are ready. Can you see the slide now?
Yes, sir.
This is LA, descending aorta, LV on top, and this is RA, and there is no tricuspid valve which is opening in the RV. This is a classical example for tricuspid atresia.
Okay, sir.
Now see it carefully. Now you can ask me question why this chamber is dilated if there is a tricuspid atresia. So this patient has got a small ASD through which the blood is coming to tricuspid valve, right ventricle. When you can't see a tricuspid valve, it looks like a membrane. This is known as tricuspid atresia. Okay?
Okay, sir. Okay.
Right. Okay. Sanjeet, Sanika Kadam. Dr. Anuj,
Yes, sir.
any question?
Sir, do you have any slide for double aortic arch?
No, I don't have a double aortic arch.
Okay, sir.
Anything else, Anuj?
No, sir. About isomerism, somebody has asked already, sir.
I've written it down. Questions, I've written it down.
Okay, sir.
Okay. Vibhusha, Dr. Deepak,
Yes, sir.
any questions?
No, sir.
Dr. Vivek Dwivedi,
Yes, sir. Yes, sir.
any question, Vivek?
No, sir. No, sir.
Avinash Solanki,
Yes, sir.
anything?
No, sir. No.
Dr. Virendra Kumar Bhardwaj.
Yes, sir. Good evening, sir.
Good
I
evening.
was listening to that.
Any question, Virendra?
Sir, I was actually driving right now, so
Okay, fine.
next class I will ask. Sir.
All right.
Thank you, sir. Thank you so much. Wonderful class, sir. Very nice.
All right. Anybody who has got a question before we call it a day is almost 3 hours long. All right. I must say thank you very much for being patient and listening to all these
Thank you too, sir.
question answer sessions, and enjoy your day. And next coming
Thank you, sir.
Friday, I'll keep a live demonstration. Keep your question in mind, which you want to see personally by hand. How do we make images on all these kind of a thing? Especially people who are asking IVC, SVC, aorta, then transposition of great vessels, then D loop, L loop, isomerism. I'll try to show each and everything over there.
So Friday, what time?
Friday, Rupali, I'll try to keep it at 6 because I have to move my whole of my staff to do a live demonstration.
Okay, sir.
So I know like it could be difficult to many of you, but please keep your time spared for that day.
Okay, sir.
All right. So may I say Shabba Khair? Good night.
Good night, sir.
Thanks, sir.
Good night.
Good night, sir.